Today I've come from Public Health England to talk about the importance of good quality cancer data and some of the work that Public Health England do in producing that data, and also why that's pertinent to UK Biobank as we link those data sets together and then supply that data on. I'm going to cover just a brief overview on what is cancer registration and how exactly does it work. It's quite a complicated process and a lot of work goes into it. Secondly, then why do we do all that work and what are the benefits and the why? I'll do a little bit on how the data are used, and then also I'm just going to cover a bit of the data that's available through UK Biobank and some of the future hopes, and we're going to get that data through. So, what is cancer registration and how does it work? There are about 170 healthcare providers providing cancer care for patients in the country, in England. Within those, there's about 1,700 or more multidisciplinary teams made up of consultants, cancer nurses, radiologists, oncologists, who all work together to provide the best treatment for the patient. And they store that information across over 500 different data systems across the country. So there'll be patient administration systems, pathology systems, MDT systems, and each of the, lots of the providers have their own and bespoke systems. However, they all do generally feed into 12 data standards across the country. So those are the Trust PAS systems, the Cancer Outcome Services dataset, pathology datasets, molecular, radiotherapy and radiology, and chemotherapy datasets. They also feed into cancer weights data and death certificates for ONS and some patient surveys and PROMs, and then certain audit data. So the Cancer Registration Service, which is run by PHE, is made up of 8 regional offices around the country. It used to be 8 separate cancer registries, but they merged into one in 2012, 2013. And there's around 120 registration staff who have access to these data that are made available by the trusts. And they sit and they individually process each of the cancer registrations to ensure that the cancer registration data is complete and to the best quality, and ensure that the cancer diagnosis is confirmed. Each year, this last year, there were 470,000 registrations, and we have a historical record of 12.7 million cancer registrations that have been fed into a single Encore system. As I said, there were 8 original cancer registries. They are all now working with the same data system, which we call Encore. Encore allows all of those data sets from above and the data sources to be pulled into a single screen for the cancer registration staff, and then they go through that and pick out the pertinent bits of information for the diagnosis and finalize the registration. Encore is a world-class service. It's possibly the largest and the largest breadth of data available in any register in the world. It's been around for, the data in it is over 50, some of it's been collected for over 50 years. And as I said, there's nearly getting on towards 500,000 registrations each year. However, we collect all this data. The next bit is, what do we actually do with these data? So PHE internally use the data for numerous web portals that we produce: cancer data, fingertips, cancer stats, visualization tools. We also feed the data into national reports, national campaigns, national audits, and data is fed back to the charities to support some of the work they want to do, such as Cancer Research UK, Macmillan. We feed the data into strategic review for NHS England, and also into international review for comparisons between data sets. However, the one thing I left out on there is research. One of the main bits, one of the large areas of work that we do within PHE and within my role as in the Office of Data Release is we provide data to researchers across the country to allow them to undertake academic research. And as part of that, we also supply data into UK Biobank. So that's how the data is collected. There's an awful lot of work that goes into it. 120 staff working full-time to get those 500,000 records each year. What does it give us in terms of why is our data, or why do we feel our data is better than the other data sources? Okay, we have a confirmed diagnosis. Now, that sounds like an odd idea, but a few people have spoken today about the other data sources that are available. Confirmed diagnosis for cancer is a difficult one. A patient can come in to go to see their GP. The GP sees and says, it looks like you may have a cancer, refers them into hospital. They go in to see a consultant in the hospital. The consultant may say, yes, you need to go and have a scan, an MRI, a CT scan. The patient then goes and has that. They may then have surgery. After surgery, they may then have that tumour that was removed or the growth that was removed sent off to pathology. And it may be when that pathology comes back that we finally get the confirmation of diagnosis. Now, all throughout their hospital records, they will have a diagnosis recorded as though they had the cancer, even if that tumour, when it came back from pathology, wasn't confirmed as diagnosis. So if we use HES data alone, we end up with an overestimation slightly of cancer diagnoses. So the cancer registration gives us a confirmed diagnosis. We have, as I said, 120 staff who check across the whole of the cancer pathway for the patient, and they use that to complete the registration. They're all trained for many, many months on ICD coding and clinical coding. On top of that, we also have almost 100% ascertainment for cases, because we have all the multi-sources of data across HES and such, and also each of the data items quality assurance checked by a team separate to the registration staff. What does it add in terms of the benefits of the data? Okay, we get confirmed diagnosis dates. We know what the basis of that diagnosis was, whether it was from pathology, whether it was at the point of surgery, whether it was from imaging. We have information on the tumour site and the morphology or type of tumour that was. We have information on the stage of the tumour. So we have tumour size, whether there was nodal involvement, metastases. We have markers for whether there were treatment, surgery, radiotherapy, chemotherapy, hormotherapies delivered. We now have information on the diagnostic imaging for those patients, and we know what was done. We also link into the HES data. We link into the HES inpatients, outpatients, and A&E data. And we use these data as well to value add to other data we have, and it allows us to recalculate ethnicities for patients and also to look for comorbidities for patients. So those are other things that the patient may have wrong with them besides their cancer, which may affect either their cancer treatment and also their outcomes from cancer. We have information on radiotherapy that's delivered to the patients and also information on SACT, which actually stands for Systematic Anti-Cancer Therapies. So they include chemotherapies that are delivered and hormone therapies. We have those at the level of the actual exposures of radiotherapies that were given and also down to the drug level for the chemotherapy drugs that were delivered. We use the data we have to produce routes to diagnosis, which identify which way the patient came into the service. So whether they came in GP referral, emergency presentation, through screening, and we have that information captured. We also have other information. So we have the 2-week cancer wait times, the cancer audit data that's available, CPES data, and patient-reported outcomes measures. These next few slides I can't take credit for. They were made available to me by one of my old colleagues, Professor Evan Morris at the University of Leeds. And I'll just quickly try and give you examples of how we've used these with linked data across the thing. So in rectal cancer, there are options, surgical options as to how the patient can be treated. Some of these, however, have better outcomes than others. And in particular, the abdominoperineal excision is one operation that doesn't have particularly good outcomes for the patient and also leaves the patient with a permanent colostomy. So using cancer registration data linked with HES data, we were able to identify the cancer patients with rectal tumours and then identify which surgeries were delivered for using the hospital inpatient data. And as you can see on this graph, the blue lines at the bottom, the lines up and down represent individual trusts, and the blue represent the proportion of patients receiving an abdominal perineal excision. And as you can see, there's massive variation across the country, which is unacceptable, as it doesn't give the best outcomes for the patient. This work went on to change the practice in the country and also increase training for surgeons within the country. We've also managed to link the cancer registration data into the bowel cancer screening data. And the main thing to show from this is this first column here. And you'll see these are stage 1, stage 2 tumours, and these are stage 3 and 4. As you can see, patients were screen detected so who've gone through the screening service, have a stage shift towards stage 1 and stage 2 tumours compared to the non-participating, non-invited participants. Again, this piece of work looks at patients who had a colonoscopy, so that's a colonoscopy, and then have, after a 6-month period, gone on to develop a colorectal tumour. And so what we would hope is that the colonoscopy would detect those colorectal tumours, but as you can see, over time, obviously, patients can develop those. Looking across the years, as the colonoscopies have come forward, you see that that rate has dropped, showing an improvement in the service across those years. And just quickly, the last slide is what is available through UK Biobank. It's been mentioned, we've linked the NCRAS data, has been linked to UK Biobank using a pseudonymized linkage. Originally, there were 63,000 participants identified, with 60% prevalent and 40% incident to their UK Biobank participant date. And we have basic cancer registration data available at present. We have diagnostic dates and basic tumour information. And we've just carried out a new linkage on data up to 2015, which identified 78,000 linked tumour records. There are opportunities of all the data sets I've mentioned for how these could be linked into UK Biobank and made available, whether those are the HES data, the ethnicities and comorbidities, radiotherapy and SACT, roots to diagnosis, or any of the other data sets I mentioned. And that's all from me. Thank you.